So when you think about juvenile dermatomyositis, obviously the name itself says a lot of things. There is dermato, that is skin involvement, myositis, that is muscle inflammation happening in a child, right? But I've seen clinical scenarios, I've seen junior residents do this mistake that as soon as a child comes with a muscle weakness, any sort of skin rash, any type of skin rash, you jump to dermatomyositis, right? So that is also something that you should be careful about. There are certain mimics, there are certain important differentials that you should rule out before you think about a juvenile dermatomyositis. So let's take it forward in the form of a case. There is a patient, there is a child who presented in February with a rash in the form of an erythematous rash, started on the face, progressed to involve bilateral cheeks, scaly rash, very important, on the dorsum of the hands, aggravated by sunlight exposure. That is, there is some sort of photosensitivity. Also, there is some evidence or there are some stigmata of muscle weakness in the form of difficulty in climbing stairs, squatting, rising from sitting position. All of these, like difficulty sitting, raising hands over the head, combing. Let's assume it's an 8-year-old female, right? So she's trying to comb the hair, not able to do that. This change in voice, difficulty in swallowing. Understand what are you able to kind of zero in here? What is the location of involvement? It is the proximal musculature and the pharyngeal musculature. It is not the distal musculature. There is no difficulty in moving the hand doorknob, or there is no difficulty in using the key. There's no difficulty in holding a utensil. These are distal musculature abnormalities. These, what we talked about, are proximal musculature abnormalities. At the same time, there is some important negative history. There is no fever or alopecia. That is, there's no something like a pediatric lupus kind of thing. There are no joint pains. There's no bluish discoloration, hardening of skin. Again, all of these are something that happen in juvenile scleroderma, right? That is also not there. There's no difficulty in writing, picking objects, as I was telling you, wearing slippers, no difficulty in distal muscle movement. There's no difficulty in breathing, chest tightness. Very, very important, because remember, ILD can happen in children, can happen in juvenile dermatomyositis, but it's lesser when you compare it to an adult dermatomyositis. Nasal regurgitation of food, drooling of saliva, in this case it is not there. So this is obviously images from Nelson. So this is the facial rash of juvenile dermatomyositis, erythema over the malar area with violaceous heliotropic distribution of the eyelids. Now, how do you differentiate this from a lupus rash? Very importantly, the nasolabial sparing, that is this particular area being spared, is characteristic of SLE. In dermatomyositis also, it's not that it is always involved, or if it is if a nasolabial fold is involved, then only I'll call it dermatomyositis, nothing like that. But not as typical of that sparing is there in JDM as you compare it with a neonatal or a juvenile SLE, right? In the rash of juvenile dermatomyositis of the dorsum of the hand, again very important to compare it with an SLE. Here there is involvement of knuckles. The knuckles are involved in JDM. That is what you call it as a Gottron's papules. The knuckles are involved. Both the PIP joint areas as well as the MCP metacarpophalangeal joint areas, both of these knuckles are involved. While if you look at a rash of, again I'm not sure this will be as a little bit in depth, but important, as a pediatrician you should know this clinical thing, that in juvenile SLE the rash will be in this particular area. It will be violaceous, it will be erythematous, similar rash only, but it will be in this particular area, kind of in the interknuckle area it will be there, right? So nasolabial fold involvement not always, but more as you compare it with an SLE, Gottron papule, and nail fold thickening is also seen. CNS examination is important because of the differentials that are various muscular causes, neuromuscular causes, neurological causes. But here, as you can see, most of the, like almost all of the examination shows that there is no LMN, UMN lesion. There will be decreased reflexes, but again, that is not because of it's 1 plus, not 0 or something. It's 1 plus not because of the LMN lesion, but because of the muscle weakness itself. Same with the bulk, same with the weak gag, husky voice, etc. Muscle power, as you will do in the examination, has shown decreased muscle power of around 3/5 to 4/5. Again, not involving the distal musculature. It involves the neck flexors, it involves the pharyngeal muscles and all, but not the distal musculature. Now we come to what I was talking about. Why are we discussing this case? We are discussing this case and we have not jumped to juvenile dermatomyositis because this is a condition where mimics are very important to be ruled out. Do not jump to the diagnosis. It's a very common mistake, and it's something also important because JDM is not very common. Juvenile dermatomyositis is not very common in compared to its differentials. So whenever there's muscle weakness in a child, what do you think about? You think about muscular causes by itself like dystrophies. You think about neurological causes, various LMN lesions. You think about endocrine causes, sometimes hypothyroidism, hyperthyroidism, Addison's for some reason, Cushing's. All of this can lead to, metabolic syndromes like inborn errors of metabolism. All of this can lead to muscle weakness. But you are also talking about a rash here. So when you talk about rash, these differentials kind of go down while some other differentials still stay. One differential that apart from these two are the drug causes or the toxin causes. Toxins or your drugs like colchicine, etc. All of these can cause a rash as well along with this muscle weakness. So that is another very important. Drugs or toxins or even porphyrias can cause rash along with muscle weakness, right? These are very, very important. Now we come to our two main things that you should immediately think about as soon as you see rash with weakness. That is your infective causes and rheumatological causes. You should rule out drugs, toxins, etc. But you should mainly think about these. Infective cause, will be a little bit acute onset, not as chronic as a prolongation. There will be some, geographical distribution depending on the cause, like ticks, etc. are more towards Himachal Pradesh in our, Indian region. Then there will be high grade fever. Compare it with rheumatological cause, you will have fever which is more prominent. In your rheumatological causes, fever will be less. Systemic complaints will be more. In your infective causes, less in your rheumatological causes. In your rheumatological causes, it will be subacute to chronic in onset and duration. Joint pain, joint swelling, photosensitivity, all of these are important findings that again move it towards your rheumatological differentials. So what rheumatological? Not just juvenile dermatomyositis. As we discussed, SLE is an important differential. Systemic onset JIA is an important differential. Scleroderma, MCTD, all of these are important differentials. Similarly, in your infections as well, it can be bacterial, it can be parasitic, as I told you. It can be viral, it can be trichinella, all of these, tick typhus, all of these can be there, right? So that is with respect to differentials of a weakness with rash, which is very important. And also, how do you differentiate an inflammatory myopathy versus non-inflammatory myopathy? You are talking about myopathy only, not another cause. Myopathy like a muscle dystrophy or something. So such myopathies will have, obviously, this pseudohypertrophy and all is classic for your non-inflammatory myopathy. Rash will be less in them. Muscle tenderness, fever, systemic signs, all of these will be more in your inflammatory myopathy. Apart from that, proximal muscle weakness. As you know, in your non-inflammatory myopathy, there are conditions where proximal predilection is there, but there are many conditions, there are many distal myopathies as well, right? So myopathy can be proximal or distal, not very, very predilected towards a proximal musculature. Age of onset, yes, usually your muscle dystrophy is present much, much earlier than your inflammatory myopathies. Let's come to the topic proper, that is juvenile dermatomyositis. It's the most common inflammatory myositis in children. Peak age of onset, again, very rare to find someone of a 2-year-old, 3-year-old, 4-year-old. In that age group, if you are thinking about rheumat in a 2-year-old, think Kawasaki disease. Very rarely do you find much other, apart from autoinflammatory syndromes, of course, or inborn errors of immunity. That's a different story. Those are autoinflammatory syndromes. About autoimmune syndromes, main thing is Kawasaki disease. Apart from that, usually most of the autoimmune diseases are around about the age group of 6 to 15. If you look at one of the most classical, rheumatological illness, SLE, it's not even up to 10. It's usually above 10 only. JIA, of course, it can present at any age group. Systemic onset JIA, any age group. Oligoarticular JIA, it has early predilection. Also, in some cases, RF negative polyarticular JIA can happen less than 5 years, but all of the other, most of the other autoimmune conditions after 5 to 10 years. Similarly, here also it is 5 to 10 years. Most of the autoimmune conditions, girls more than boys. Here also girls more than boys. Etiopathogenesis is not so important like any other autoimmune disorder. There is genetic susceptibility with HLA. Again, I don't want you to remember the various HLAs. HLA-D are something, are the main, HLAs that are involved. Group of streptococcal infection, especially in your pediatric rheumatological disorders, most of your rheumatological illnesses can be mapped to some recent infection like a group A, Streptococcus, Coxsackie B, Toxoplasma parvovirus, etc., etc. Environmental triggers, immunological mechanisms, again, won't be asked in your NEET SS or your MCQ based exams. Clinical features, very important. Skin lesions we discussed. I showed you how the heliotrope rash looks like on the face. I showed you how the Gottron's papules look like. Right? These are the two. Again, I'll show you again. Yeah, so facial rash of juvenile dermatomyositis, it's called the heliotrope rash. It's violaceous. It is usually periorbital, can or mostly does involve the nasolabial fold, while Gottron's papules, they involve the knuckles, they spare the inter areas, they are papules, they are erythematous, they are flat topped, etc., etc. They can be hypertrophic, pale red, etc. Right, so this is about the rash of the eyelids and the Gottron papule. Apart from that, especially in children, when compared to adults, there is a lot of vasculopathy that occurs. Vasculopathy is abnormality or pathology of the microvasculature. This vasculopathy leads to certain skin manifestations. What are they? Ulcers, lipodystrophy, calcinosis, very, very important. These are very, very important manifestations, even lipodystrophy as well. So these are crucial microvasculopathies that occur that you should remember. Raynaud's phenomena also is a kind of microvasculopathy. All of these manifest in the form of periungual capillary changes, and they can eventually lead to abnormalities on an investigation that is called nail fold capillaroscopy. We'll come to that because a lot of research has been going on, and a very recent INISS question in your general pediatrics part was asked on that. So all of these microvasculopathy abnormalities cause changes in your nail fold capillaroscopy, and they are manifested in your nail fold capillaroscope abnormalities, right? Apart from that, there is joint involvement. Like most rheumatological illnesses, joint contractures, fever. Joint not contractures can occur, definitely can, but they usually just joint pains, arthralgias, arthritis, and fever. Muscle weakness, obviously very important. Dysphonia, dysphagia, muscle atrophy, all of this can occur. Respiratory failure, yes, if respiratory failure occurs, you should consider IVIG. That is one of the indications for your IVIG in rheumatology. Apart from that, other features, these are usually less. Cardiac involvement, ILD, these are usually less in your juvenile dermatomyositis. GI symptoms, yes, they are more compared to adult, again because of vasculopathy, GI vasculopathy. They are more compared to adult, but your cardiac, ILD, even malignancy. Malignancy is a big consideration in your dermatomyositis in your adults. These are the ones, these three are the ones. I'm putting them in green because you can understand that these are less in juvenile dermatomyositis, right? So this is what you should understand. Now coming to skin manifestations, again it is important that you know the how it is described, because every word can be presented or written in a clinical vignette, and they can ask you what is the diagnosis. Bluish violet or violaceous is one of the key clue or key words to help you identify that it's a heliotrope rash. Periorbital is very important, involves the nasolabial folds, very important. Then Gottron papule, pink, pale, shiny, hypertrophic, thickened or atrophic sometimes. Small vessel inflammation, I told you, vasculopathy in the nail fold, nail fold capillaries, telangiectasias, all of this can occur. Shawl sign, V sign, not very common in your pediatric age group as a description, because again, it's the body surface area is not so much to form a V, right? But yeah, these are two signs that are important. Why? What is this shawl sign? When you wear a shawl, it kind of spills over onto your back, right? So that is this is the shawl area. So this is the shawl sign, while this is the V sign. V sign is your this V that is there, collar area, right? Shawl sign, V sign. Now Bohan, modified Bohan-Peter criteria, not asked before in your NEET SS, asked in your INSS, but I'm not sure if it was in the general pediatrics part or the peds rheumat part. But yeah, it can be asked. Here, main thing that you should remember, more than the cutoff. So it is classic rash plus 3 out of 5 of these things. So more than remembering this 3 out of 5 and all, what is more important is understanding what are the components. So classic rash, including heliotrope, Gottron papule, this should be there for a juvenile dermatomyositis diagnosis. Again, this is according to this criteria. It's not a gold standard criteria. There can be a child without rash, and he or she is a juvenile dermatomyositis. But according to this criteria, which is a diagnostic criteria, here you have to have a rash plus you have to have 3 out of 5 things. What are the 5 things? Weakness, proximal symmetric muscle weakness, muscle enzyme elevation, electromyography changes, biopsy or MRI evidence. So you should have evidence of this muscle involvement, either it be MRI, either it be biopsy, either it be EMG, or either it be enzymes. That is what is your diagnostic, modified diagnostic criteria, Peter and Bohan 2010. There is ECR ULR criteria, there will be British Society of Rheumatology criteria, there will be Australian rheumatological criteria. All of these criteria will be there. Not required to know the criteria. Understand what are there. You should know that there is muscle weakness, skin manifestation, dysphagia, esophageal motility, dysmotility can occur. Lab involvement in the form of enzymatic elevation is important. Biopsy features is important. Then these can classify definite IIM without more than 90% probability, with or without muscle biopsy. And muscle biopsy not required for definite diagnosis if skin rash is present. So muscle biopsy is not something that you should do just as a child comes. You think that, okay, I have to fulfill that Bohan criteria, so let's do muscle biopsy and MRI immediately. You don't need it. If you have a rash, if you have a weakness, you have a muscle enzyme elevation, still it's a very highly possibility that it is a JDM. You may get EMG done, or if it is very, very classic, you may not even need that. That is how you should make a diagnosis. You don't need to always keep fulfilling criteria to make the diagnosis, right? So again, to understand from a pediatrician perspective, what do you look for? Apart from weakness, you look for the systemic abnormalities, you look for the most important clue, that is the rash with involvement of nasolabial fold, Gottron's papules, or if it is in the palmar area, on the ventral surface, on the knuckles, they are called inverse Gottrons. So it can be Gottrons, it can be inverse, it can be Gottrons on this side, it can be inverse Gottrons on this side. Joint examination with calcinosis. Calcinosis is a very important clue. Again, as I told you, this is one of the things that is more in your juvenile dermatomyositis. As I told you, they have put it in dark red: ulceration, calcinosis, lipodystrophy. These are 3 things that are more in your, even GI ulceration, especially the ulceration part of things. These are more in your childhood than your adult. Then you have your assessment of power, gag reflex, because there can be pharyngeal musculature involvement. Remember, there can be pharyngeal musculature involvement, but extraocular muscles, which are usually involved in your neurological causes or neuromuscular causes, they are not involved in juvenile dermatomyositis. Pooling of secretions, dysphonia, all of these can occur in your JDM. So once you're done with the clinical aspect of things, once you have done your OPD evaluation, initial ward evaluation, because obviously most of the cases of juvenile dermatomyositis might require admission as well, especially if it is a very acute onset, especially if you're noticing any pharyngeal weakness, if you're noticing any neck flexion weakness, definitely the child needs admission. Once admitted, you have to obviously investigate. What will you first investigate? Your blood labs, right? So you will see your enzyme elevation, ALT usually very early, AST also very early, then comes CK. Again, it depends on the type of muscle involvement as well, but usually it is all of these: aldolase, CK, LDH, AST, ALT, which are the main enzymes. ESR, many times it's normal. It's not like, it's a very basic mistake that many times residents will do ESR, CRP and say it's normal and this is not JD. Doesn't work like that. The sensitivity, specificity are not 100%. Here, many times there will be false negatives. RF is typically negative because obviously nothing to do here. ANA, very importantly, 80% of the cases it is positive. Then there are specific antibodies. For example, you have various, blots that you do. In SLE, what do? You do what is called an ENA blot, an extractable nuclear antigen blot. So in that you have your classic SLE antibodies, like your Smith, Rho, La, dsDNA, all of these come under what is called an ENA blot, or sometimes in certain labs it's called lupus blot. In this particular scenarios, the antibodies are different in myositis. Here you do what is called a myoblot. In that myoblot, you have antibodies. Those antibodies can either be seen only in myositis, in which case you call them myositis-specific antibodies, or they can be seen in myositis plus certain various other conditions as well, like overlap syndrome, scleromyositis, etc., etc. We'll come to that. So next most important step is doing this myoblot and seeing the specific antibodies and associated antibodies. Then radiological, 2 important things in your juvenile dermatomyositis: X-rays, very important, because underlying calcinosis is a real thing. Many times we won't see your white chalky deposits on the skin. The child may not even tell you, but there can be some subcutaneous nodules. Just like adults have lipomas, similarly small subcutaneous nodular masses can be seen in JDM unnoticed. Those are calcinosis which will slowly develop, progress and rupture. Then they'll become irreversible. Treatment of calcinosis is really difficult, and there's no good evidence for that. So calcinosis you should screen. Then obviously for the diagnosis you do an MRI. T2 weighted or stir MRI is what is the modality that you use. Muscle biopsy you either do when there is diagnostic dilemma, when there is something like a trial going on or for a research purpose, or clinically, I mean, you are suspecting some other type of myositis. So here we are discussing only juvenile dermatomyositis, but there are certain other inflammatory myositis examples like immune mediated necrotizing myositis, inclusion by body myositis. When such myositis are there, especially when you're suspecting what is called an immune mediated necrotizing myositis, there you will think about muscle biopsy. No need to remember all this, but what you should remember is that muscle biopsy is not a compulsory or a mandatory investigation. Only in certain scenarios you will do muscle biopsy, and in that muscle biopsy you have to remember one word, that is peri. For juvenile dermatomyositis, remember peri. Perifascicular and perivascular, these and perimysial, these are the areas where pathology occurs. Perifascicular atrophy, perifascicular inflammatory infiltrate, perimysial inflammation, perivascular inflammation, very important. Some necrotic fibers can be there, but remember this peri thing. Then we come to the antibodies. Antibodies, this image also has been given in your Nelson, so it's a very likelihood. This is given in your 22nd edition Nelson. So again, it's something that is likely to be asked, right? So in your 22nd edition Nelson, this is the main table that is there in your for your myositis apart from the images. So myositis-specific antibodies, you have your TIF1 gamma and NXP2. These are the two antibodies which are the most common in children. Right. So apart from this, you also have certain associations of clinical manifestations that you should know with these antibodies. For example, TIF1 gamma, as you can see, each one of these has certain names. For example, NXP2 is also called MJ, and TIF1 gamma is also called P155, P140. I think you should remember them because it's mentioned in the images and the tables. I feel it is important. Then definitely only these two names have some, dual names. TIF1 gamma, P155, P140, and NXP2 also called MG, right? So in your TIF1 gamma, mainly you have your skin involvement, severe skin involvement. I told you vasculopathy, like your lipodystrophy, ulceration, all of this occurs. Apart from usual myopathy and rash. In your NXP2 MJ, main thing that is happening here is your calcinosis. I feel this is something that can definitely be asked. Here also cutaneous ulceration, cutaneous disease is there like TIF1 gamma, but the main thing that is there is calcinosis, and because of this there is a poor prognosis because of refractoriness to treatment. Very important. MDA5, again, two very important things. Both are eyes. One is the ILD, another is the, I think it's not given in the image, it's given here, that is inverse Gottron's rash, that is on the palmar side, palmar papules, palmar papular rash. Apart from, another important thing, that muscle weakness is actually mild here. As if you can see in this image, if you can see in this whole image of your MDFI, there's nowhere where muscle involvement is kind of highlighted. If you can see here, muscle is there, here muscle is there, here where is the muscle, here there's no muscle involvement highlighted. What does that mean? That muscle disease is mild in your MDA5. You can remember it as MDA5, muscle disease absent or very less, not absent per se but very less, right? So that is also very important MCQ. Apart from that, there are two eyes, inverse Gottron and ILD. MI2, very good disease in the form of prognostical, it's very good, benign disease, cutaneous features, classic features, etc. are there, but it is very normal disease. Jovan is, I think you might remember this from your PG preparation days, anti-Jovan antibodies is seen in something called an anti-synthetase syndrome. Antibodies are against your histidyl tRNA synthetase, antibodies are there, right? Against this enzyme, antibodies are there. So here the mnemonic, if you can remember, but at least minimum you should remember mechanics. And apart from that, the mnemonic is fever plus Raynaud's plus mailed. Mailed is mechanics hand, arthralgias, again these are arthralgias or non-erosive arthritis, and ILD. So this is the mnemonic for your anti-Jovan syndrome or your anti-synthetase syndrome. SAE and SRP unlikely to be asked, very less common in your JDM, right? But yeah, both of these have ILDs and SRP has cardiac involvement that you may remember. Then we come to your myositis associated antibodies. As I told you, associated means what? There can be in other conditions apart from myositis also. They will be there in myositis, but can be there in other conditions. Like here, what is PMSL? This polymyositis, this is scleroderma. Here you can have your other everything that is seen in your scleroderma like ILD, cardiac involvement, etc. UNSNRNP is again a mixed connective tissue disorder, again very decent prognosis, except sometimes ILD can be bad there. COO is for overlap syndrome, Rho52 as we know is for Sjogren's, SLE and all. So these are myositis associated antibodies. MRI findings, as I told you, in biopsy it is your peri that you should remember. In MRI it is more of an inflammation, edema. These are the two words. Hyperintensities on T2 weighted hyperintensities will be there. Muscle edema, muscle inflammation, perifascicular edema, all of these inflammation, edema, intensity. These are the words that you should remember in various perifascular and your muscle areas that are there. Now we come to a very important investigation, that is nail fold capillaroscopy. I don't think for your NEET SS level they will try to ask you the various process of nail fold capillaroscopy and all. Just remember, it's a instrument. It can look like a microscope, it can look like an ophthalmoscope. Various types of NFCs are there. You're basically looking at this area, the nail fold, and you're looking at those capillaries. If you look at this nail fold, if you look closely, you will see certain reddish capillaries that are there. Very difficult with a naked eye unless you have a very clean very fair clean skin. It's very difficult to look at those capillaries with the naked eye. But even if you use a 5x microscope, 10x, even if you use a phone zoom, you can see capillaries here. That is only, they are only seen at 40x, etc. And here they are kind of, their structure is seen, microarchitecture is seen there. If any hemorrhages are there, they are seen. If any new angiogenesis is there, that is seen. All of this architecture is seen. Normally it is like this. This is the hairpin shape, reverse U shape or hairpin shape. That is a normal appearance. But in juvenile dermatomyositis, very importantly, two things. What happens? Bushy capillaries with exuberant branching, and most importantly, elongated enlarged loops. This is the most common manifestation, but bushy capillaries, etc. are also quite common. Why is this important? Not because it's abnormal. Yes, we know it's abnormal, but why are we discussing so much on this? Because this is associated with the duration of untreated disease. So it's kind of a prognostic marker, and also it can help you find the association. How? If you have a hemorrhage, that means possibly cutaneous disease activity will be high. If you have avascular areas, that means possibly lung disease will be high. More progressive disease, lung disease, pH will be high. If you have loss of capillaries, that is again similar to your avascular areas, only your overall disease is bad. If you have ramified capillaries, ramified means long standing disease, because it has time has been there for ramification or branching to occur. Most importantly, hemorrhage with cutaneous disease, avascular areas with lung disease. This is very, very important. That is why we're discussing. We have 3 slides on NFC patterns of juvenile dermatomyositis, because it's a prognostic marker. It can detect early relapses, plan treatment strategies, etc. Additional testing, I told you about muscle biopsy. Always remember peri, always remember perifascicular, perivascular, perimysial, inflammation, damage, atrophy, all of this. EMG, again, main thing that you should remember, although amplitude is decreased, there is increased insertional irritability, one of the most specific signs of inflammation. Again, it's an inflammatory myopathy, so insertional irritability, fibrillations. Insertional irritability is a better word. Here its activity is written, but fibrillations, again, I is prominent here. So fibrillations, insertional irritability, sharp waves, all of these are more classic, while your amplitude and duration is usually decreased. Investigations, we told you, enzymes, antibodies, radiology and muscle biopsy, which is a question mark. You may or may not do. Then you come to management. Management is something that I'm pretty sure they won't ask you in depth, but you should understand how to treat, right? So main treatment is again immunosuppression, but here you will use agents. Don't just rely on your steroids. So here you will have general support measures, especially if the child is admitted, definitely you will give him support. If there is severe pharyngeal weakness, he may even require NG feeding. If there is severe respiratory weakness, he will require respiratory support, physiotherapy, etc. And of course, you will give supplements and photosensitive, photo protection. Steroids are the mainstay, especially in the early phase, because you have to suppress the disease, especially if there is severe disease activity, pharyngeal weakness, you should consider pulse methylprednisolone. Apart from that, some immunosuppressive agent, if it is mild, initially you will consider methotrexate. No, if it is not responding severe, then you will consider cyclophosphamide, immunomodulation with IVIG, MMF, etc. Still not working, rituximab biologicals. So there is a very crude way to tell you. There are flowchart, there are guidelines from various societies, but in a crude way I'm telling you, because that is all you need to know. You cannot sit here remembering the main management guidelines of JDM, right? So let's again, so primary therapy, all of these options are there. Refractory disease, all of these options are there. This is what is mentioned in your Nelson. I think again, this is also not very much evidence based. It says moderate JDM, do this skin, but this is according to CARA guidelines, right? So CARA guidelines are something that are decently approved or decently valued in rheumatological settings, so you should look at that. So plan one for moderate JDM. Remember, this is for a moderate JDM, neither very severe, not very mild. Like this is something like a mild, that is skin predominant, nor it is very severe, that is moderate. So start with steroids, prednisolone. But if it was a severe disease, that is plan 2, then you will start with a pulse, then decrease the pulse, and along with that you will give methotrexate. But no, if it was very severe, that is there is respiratory weakness, then you will definitely consider IVIG with steroids. Remember here, this is plan 2 and this, not just IVIG, plan 2 and this. So IVIG along with steroids, pulse along with methotrexate. If it is just skin predominant, sometimes it happens very much in your MI2 disease, anti-MI2 antibody disease. There you can just start HCQ or HCQ plus methotrexate or HCQ plus methotrexate plus prednisolone. Again, I don't think they'll ask you, go to this extent to ask you. Mainly remember what are the main agents. You can remember this slide. That should be enough. But yeah, if at all they ask you from this table, then better to remember this. Skin resistant, again, this is something of a severe phenotype. Then you will start with IVIG, consider MMF, cyclophosphamide, cyclosporin, etc. in your line of management as well. So take home messages, I don't think the questions should spill over apart from your clinical manifestations, your clinical vignettes. But one area which I feel, which we have discussed, which is mentioned in your 22nd edition of Nelson, which there are a lot of research going on in your Apex Center for Pediatric Rheumatology, that is PGI, is your NFC abnormalities. Almost I think at one time there is some thesis going on with your NFC, right? So NFC is very important, especially if somebody is preparing for INIS, is 100% important, even if it is for some other speciality. For your general part of INIS is very important, and your NEET SS as well. There is a probability of questions coming, right? So mainly it is the clinical features, diagnosis, management. Just understand what are the agents that you can use and keep an eye out for your NFC abnormality.